to the Facial Paralysis and Bell's Palsy Foundation presents I Care for Facial Paralysis with Dr. John Ng. I'm Lisa McKinley, Director of our foundation, and I'll be being assisted today by our Portland, Oregon leader, Barbara Pasternacki. Our webinar today will be interactive, and Dr. Ng will answer as many of your questions as possible during the presentation. During the presentation, if you'd like to ask a question, please just type it in the Questions tab on the right side of your screen, and then we will pose the question to Dr. Ng. I'd now like to introduce our speaker today. Dr. John Ng is an oculofacial plastic surgeon at the Casey Eye Institute in Portland, Oregon. His specialties include caring for people with facial nerve paralysis issues. Dr. Ng, thank you so much for being our presenter today, and I'll now turn the session over to you.
Well, good morning, everyone, and thank you for taking time to come and listen to my presentation. And as Lisa had mentioned, I do want to make this interactive because it's very difficult to cover everything regarding facial paralysis, and everyone has different symptoms. But what I do want to cover is something that can be more like a practical approach to for patients dealing with facial paralysis. So I'd first like to thank Lisa McKinley and Barbara Pasternacki for contacting me and setting this up. They've been invaluable in bringing together the support group, and that's so important for individuals to know they're not alone dealing with this, and it's a very common thing because it can be very stressful and life-changing for sure. So I was asked to tailor this as eye care for facial paralysis, and so I'm focusing my discussion basically around the eye. But I can, at the end, if you want to field questions about other parts of the face, I do help patients with paralysis deal with other facial issues. But the focus for today will be on eye care. So if a patient, or if you have facial paralysis, or as someone taking care of someone with facial paralysis, there are several things that we need to consider practically. One is this a temporary or a permanent problem? So if it is temporary, then we can try and treat things medically as long as possible until the patient recovers. If it's permanent, there's really no reason to wait to begin surgical intervention if that's necessary, because it's not going to get better. Then the other questions to consider are the issues that I'm dealing with right now, are they stable? Are they liable to get worse? Or maybe they would get better. And again, this goes to temporary versus permanent. But the changes that people have really not only depends on how weak the muscles are, but also what underlying aging changes there are in the tissue. So someone with a severe paralysis but is very young may not have too many changes in the face. Someone who is older and has very minimal paralysis can have significant changes. So it's not necessarily only the level of paralysis, but also what your underlying anatomy is like. And then dealing with the issues of paralysis, is it really issues with not being able to move, or in patients who have recovery but synkinesis or miswiring, is it unwanted movement that's causing more of the problem? And then when you consider what the options are, you want to consider what are non-surgical and what are surgical options. So some of the issues to consider are, is this a temporary or permanent, as we mentioned? Is it regional or global? Meaning, is it localized to a specific area of the face, or is it the entire face? And that really depends on where your nerve injury occurred. So if the nerve injury occurs closer to the end, so kind of towards the ends here, whether it's from trauma, or if there was something to do with swelling in your salivary gland where the nerve runs through, it may affect less things than if it happened back where it comes out of the brainstem. If it does that, it can affect your entire face, including creating saliva as well as creating tears. So not only can you have dry from not being able to close the eye, but if your nerve was damaged to the point where the signal to make tears has been affected, you can have more dry eye symptoms than you would normally expect just from the paralysis alone. So if it's temporary, we mentioned we want to try medical management as long as possible because you don't want to do something surgically that you might have to reverse if the patient is going to get better. However, if, as I mentioned before, a lower eyelid is very loose, and even if we know it's going to be temporary, oftentimes doing the surgery on the lower lid is wise because it can make your life so much easier to handle the dryness and the temporary paralysis, and that's something you wouldn't have to undo because it's going to be in the proper position. And then to determine if something's permanent or not, if you know right away during surgery that the surgeon said, well, I had to remove a tumor, or doing the surgical procedure required the facial nerve itself to be cut and it could not be repaired, or it was involving the nerve, then you know it's permanent. So you can make that mental adjustment and say, okay, I need to move forward and deal with this. You know, this is going to be permanent. And so if it is permanent and you know that early on, early surgical intervention can make your life a lot easier. So when we look at facial paralysis, what do we see involving the face? And it can involve the entire face, as we said, or parts of the face depending on where the nerve was injured. So a very common thing is to have paralysis of the forehead, so the eyebrow can droop. But again, if you don't have a lot of laxity in your forehead, even with a paralyzed, it may not droop. You just may not be able to raise it like on one side like this. Now, when that happens, it can push down on the eyelid like we see here. However, if we know it's a temporary thing, sometimes it's wise to not do anything about this because this actually acts like a gold weight, and the weight of the brow actually pushes the eyelid down and helps you close. So that'd be the equivalent of your own gold weight, meaning your brow pushing the eyelid down. If you lift the brow up underneath, oftentimes the eyelid is open too much compared to the other side because the closing muscle, or the orbicularis muscle, which is a sphincter muscle, closes the eye like this. But the muscle that opens the eye is a different nerve, and so that becomes unopposed, so it actually opens up more underneath the lid. So you really don't have a droopy lid. You have a droopy brow pushing the lid down, but the eyelid underneath is actually too open. Down here, it can affect the face, and if your cheek is loose and your face becomes paralyzed, the eyelid can pull away from the eye or down below and expose more of the eye and cause dry eye. And in the lower face, which is not the focus of this talk, but it can affect how you chew, drooling, biting your lip, or biting your cheek when you're chewing. So those are things that also occur. So again, if it's stable, is your medical management adequate? So if your facial nerve is not getting worse, but it's slow to improve, but you're doing everything medically possible to protect the eye. If that's not enough, sometimes even if it's temporary, you have to do surgery. And if we know it's going to get better, oftentimes how long you as an individual are willing to deal with what you have now to wait for it to recover goes into the thought process of, well, should I consider some procedures that could be reversible so that I can get on with my life with the least amount of hassle, but it may require a second surgery once I recover my facial function. And then if it is getting worse, the timing is when to intervene. Oftentimes patients, especially if they have the palsy from surgical intervention, from tumors or radiation, have been through quite a lot and may not emotionally or mentally be ready to do surgery, but there may come a point where you have to make that decision. So for the paralytic issues, or the weakening of the muscles, the key thing from an ophthalmologist or oculofacial plastic surgery standpoint is eye protection, eyelid functioning, facial functioning, appearance, and then if we're going to do something, do we work on static versus dynamic procedures? So surgical intervention could be just suspending something, like if your cheek is dropped, you can suspend it up, and that doesn't increase movement, but it helps protect the eye. Dynamic procedures are maybe moving muscle from another area that is not innervated by the 7th nerve, but usually the 5th nerve, the one for chewing, moving it into an area of the face to move, or doing more complex things such as nerve transfers or nerve muscle transfers, which we won't get into here. But the order of priority is eye protection, eye functioning, and then appearance. Because with the eye protection, if your eye gets damaged, severely dry, you can get a corneal abrasion that's minor. But if you get corneal scarring, even after you recover, you can have irreversible vision loss without needing or requiring corneal surgery, like a corneal transplant. So even if you can't use the eye because we have to protect it, that is the primary goal. And then after that, eyelid functioning so that you can see, and then of course appearance. We want to make it as symmetric as possible. So there, I got a text that there was a question, so why don't I field that question at this point?
Hi, Dr. Ng.
Okay.
Are you able to hear me now? This question came in.
Yes.
This question came in about surgical options for the lower eyelid with incomplete recovery from Bell's palsy.
Yes.
It's interfering with vision and the ability to read or effectively use the visual fields in the bifocal area,
Okay.
the trifocal area. Does surgery on the lower eyelid help that, or can you describe some of the options to improve that?
Yes. So if the lower eyelid is kind of pulled down like this, okay, really the lower part of the eyeball gets very dry. And when that happens, it can make the corneal surface rough. And without a smooth surface and a good tear film, it doesn't focus the light clearly onto the back of the eye. So if you're looking down, that's going to be in the area that can be most dry in someone with a lower lid problem. So yes, if that is an issue, if the eyelid is too far down and is not protecting, many times you might see patients say, well, it wasn't protecting my eye, so they put a heavier gold weight in, and yes, that'll protect the eye, but that'll make the eyelid so droopy that you can't see, or it's so fatiguing to try and open the eye. That's really not the right answer. The correct answer is to raise the lid back into a more normal position, or sometimes a little higher if blinking is incomplete. So there are different techniques to do that. If it's just the lower lid that's very loose, a simple tightening procedure, which is very common in patients who are older, senior citizens who have looseness of the lid, they get that even without having a facial palsy. So it could be something as simple as a little tightening. However, if the whole cheek is pulling it down and you pull on the lid and it seems like, well, the whole cheek is still pulling it down, then there are other procedures that may need to be done, such as a cheek lift. So there's varying levels and varying complexities, but you can raise the whole cheek or you can just raise part of the cheek, and it just depends on how severe the droop is and what's pulling on the eye.
And with some of us with the synkinesis, she added to that question, because of the synkinesis, the eyelid gets super tight on the bottom. And so when it's closing, when you're trying to look down to use your bifocal, it causes the synkinesis to contract and affects the vision. Does that make sense?
Yes. So with the synkinesis, so there were two problems with facial paralysis. One is the weakness. The other is the unwanted movement, because when the nerve recovered, you saw in the diagram that it's kind of fanning out across the entire face. As they grow back, it's very common for them to cross wire. So, and most commonly, if you're moving your face or your mouth, it causes the eyelid to close. And if the miswiring is causing the lower lid to raise up, then the most common treatment for that is actually some very low-dose botulinum toxin, Botox. And what that does is it kind of weakens that muscle a little. Now, there's a trade-off. As long as it doesn't weaken it so much that it droops, it's okay to do so that it gets rid of the unwanted closure when you're moving other parts of your face or when you're looking down. If it turns out that your eyelid position is very dependent on that muscle tone and you inject Botox and it gets loose, it might be that the eyelid still needs tightening to support it when the Botox is so that when you get Botox, it does not cause the lid to droop and cause a dry eye. So yes, you can have difficulty seeing below. The most common is from dryness, but raising of the lid because of unwanted synkinetic movement is also common, and usually Botox is the treatment there. If the lid just stays tonically way too high, even with Botox, then you can actually surgically lower the lid, but that's much less common.
Okay, thank you.
So,
that answered it.
was there another question?
No, she said that was great. Thank you.
Okay, so management. Well, the medical management is mostly with eye protection, and that's usually with lubrication, moisture chambers, or specific eyewear. And if that's not enough, or in addition you need further protection, then that's where surgical options come in to deal with changes around the eye, but also of the face, because it's all related. So regarding medical management, the key thing is really lubricating the eye. And as far as frequency, that's very independent with each individual. How dry you are, how much tears you make, or if you actually have dry eye in addition to not being able to close the eye. So topical lubrication is, there's a whole range of them. You can have just plain tears, which are very thin and just like water, they're salt water. Then you have things that are a little bit thicker, so a little bit more viscous, so they last a little bit longer. And then you have something even thicker, they're kind of, it's called viscous tears. And then there's gels, and then there's ointment. So the balance there is usually it's ointment at night because that does blur your vision, but that'll protect your eye at night because it'll coat your eye and not evaporate as quickly as tears. Many patients often need a combination of different things. So if you are using your eyes a lot, you obviously can't put thick stuff in there because it blurs your vision and you can't do the visual task. But if you're doing the visual task, it's great to use the thin stuff because it works well and it doesn't blur your vision. And then if you're resting or just more relaxing, then you want to use something a little thicker. It may not be necessary for everyone, but those are the options. So it's not just one size fits all. It also depends on what you're doing. If you are using tears more frequently than 6 times a day, then you want to go with a preservative-free tear because your eye is already irritated because of the dryness, and it could be sensitized to the preservative. So if you're using it more than 6 times a day, it's a good idea to go to preservative-free tears. Other things as far as eye protection, there was a question that came up about computer use, and let me just back up a little bit. The normal response of the eye unconsciously is to blink fairly frequently to protect the eye, recoat the surface so that it stays smooth and so you can see well. Oftentimes, if we're doing visually oriented tasks, so reading, computer work, anything, or even driving, we unconsciously suppress our spontaneous blinking. So because of that, our eyelid is not windshield wiping our eye, and it can get dry faster. And oftentimes the symptom is, yes, I'll be able to see, and then things kind of get blurry, and I kind of have to close my eyes, and I might be able to see, and then it gets blurry again. Or I'm using my eyes, it kind of feels irritated, and then I start having lots of tears run down my face. That's because it got dry from not blinking as much. And that's made worse if your eye is paralyzed or your eyelids are paralyzed. So as far as using tears, what you want to do is get on a regimen where you're preventing the eye from drying rather than waiting for it to get dry and then putting in the tears. And the reason for that is once your eye gets dry, it gets a rough surface, and then you get reflex tearing, which is that uncontrolled outpouring of tears that people say, well, why do I have to put in tears if I'm tearing all the time? That's the reason for that. So the thought is, if you've had like dry, cracked skin and you wait for it to get all dry and cracked and irritated, and then you put on the moisturizing cream, one, it stings when you put it on because you have this dry, cracked skin, and it takes a while to heal up. But if you keep your skin moisturized all the time, it stays protected, and then if it gets wet, it doesn't sting. Same thing with your eye. I have many patients who say, well, they told me to use artificial tears, but every time I put it on, it burns. Usually that means their eye was so dry before they put it in. Tears are salt water. You're putting salt water on an open wound, so that's naturally going to sting. So if you prevent it from drying, that'll help. The difficulty with doing tasks where you have to wet your eyes a lot, it's hard to kind of stop and put a drop in and it kind of floods, and you have to have great aim. Some people need mirrors to do that. There is this product here called Nature's Tears. That's this one over here, and it looks like this. It's preservative free, and I like it because You don't have to have great aim, and so say I'm doing computer work, I can just leave it by my computer and just kind of spray my eyes like that. It feels great, it's preservative free, and it doesn't run down your face, and so it doesn't blur your vision. So if you're doing frequent visual tasks like computer work, this is handy, and that you can just get, it's not prescription, it's called Nature's Tears Eye Mist, and if you look at that, you can just get that online. The other thing about computer work is many times computers are set up, if it's in an office area, under fluorescent light. Fluorescent light is really bothersome to the eye. So if you can get the lights changed or move the, have your workstation moved so it's not directly under the light, or if it's under a vent, that vent can blow across your eyes. So if that happens, either move the workstation or they have little diverters that can blow the air a different way. So we have another question that we can field now.
Yes, Dr. Ng, someone's asking, can too much eye solution or long-term use of different eye solutions cause any problems to your eye?
So if you're using preservative-free, no. What you don't want to do is get drops that are to get the red out, like the typical old Visine. Now, Visine makes artificial tears as well, but if you have the get the red out stuff, that has a medication that constricts the blood vessels, and it feels great, but you don't want to be on that long term. And the other is, like I said, if you're using it frequently, it's the preservatives that cause the problem. If you're using preservative-free, there should be not any problem with that. Now, having said that, some people, if you're using ointment, may be allergic to the petroleum base, and if that's the case, you may want to stick with gels. So, did that answer the question?
Yes, thank you.
Okay. So you have lubrication, and so to decrease, so you want to keep the eye from drying out by wetting it a lot, but you can also keep yourself hydrated. So if you have dry mouth, you'll also have dry eye. So if your mouth is dry, remember, drink more fluid, you'll make more tears. And the other is to avoid evaporation of the tears. One other thing that was mentioned before was this Lacrocert. Okay, someone had a question about Lacrocerts. Was that the question, Barbara?
Yeah.
Okay, so the Lacrocerts, not many people have heard about that. It is a prescription, and it is kind of a little rod. It's like, think of like a cough drop. It's kind of firm and jelly-like, and you stick it behind the eyelid into the bottom part of this pocket here. And what it does is your body heat will melt that over time, and that is kind of like a constant lubrication. People who tolerate that really like it. Oftentimes it lubricates better when you also use tears, but this way you're not having to use tears as frequently. However, since it is a lumpy thing, oftentimes people don't like the sensation, so it's kind of a trial and everything. Barbara, was there another question?
There was. Angela from California came in with, "Hi, Dr. Ng. Would you discourage wearing contact lenses? I manage my mild dry eye with daily preservative-free tears." So she's just
actually contact lenses. It used to be that contact lenses were not a great idea, but the materials that they're using are really improved. So there are many different types of contact lens, and oftentimes we do have patients with dry eyes, whether they have paralysis or not, that we actually treat with what we call bandage contact lens or even with prescription. So if you have dry eye or facial palsy and you want to try contact lens, that is definitely reasonable. You need to see someone who is well versed in using or fitting people with contact lenses for dry eyes, because it's not a one-size-fits-all. There's a lot of different types. And we actually have a specialist here who I think Barbara is lining up, who fits medical contact lenses. His name is Dr. Louie. Mm-hmm. And they even have some that they're very expensive, but this is, again, in more severe cases where you have a contact lens that you fill with solution and you put it on your eye, and then during the day it actually leaks out the fluid onto the surface of the eye and protects the eye. So yes, if your contact lens feels good when you have it on and it's protecting the dry, that's a good thing to do. But you also have to make sure that you keep it lubricated, because if it gets too dry, that can actually cause a problem.
Okay, thank you. And from Janie, she asked, tearing is beginning to affect my driving. Will the nature's mist that you talked about help?
If your tearing is due to dryness and reflex tearing, so in other words, you're concentrating on driving, and if you're in California, it's really sunny, except when you had that rainstorm, and it dries out, then what will happen is your eye will get blurry and you'll start tearing, and that'll blur your vision. So many patients who I have and drive a lot often use the nature's tears mist to actually wet their eye, and it's really great to do, like if you're at a stop sign or stoplight, it's just right there. You don't have to stop. You just spray it. Unless you're wearing glasses, you may have to take that off. But that does work well as long as it's reflex tearing. Now, having said that, there's a condition called crocodile tearing, which is tearing when you're normally supposed to make saliva. So remember we said there was a whole bunch of nerves, and if it goes further back, it could affect your salivary production and your tear production. Well, the facial nerve does tell your glands to secrete, and if the one to the salivary gland miswired and went to the lacrimal gland or the tear gland, then anytime you're hungry, or if you're sucking on a candy or anything like that, or if you're munching in the car while you're driving and you're tearing, and it's related to eating or eating-related activities or hunger, then the tears won't help that. Unfortunately, that's an uncontrolled tears, and the only way to deal with that, if it's a big problem, is to surgically put in an artificial tear duct that can handle that extra flow of tears. So we talked about putting more lubrication in the eye, and then also we need to talk about preventing evaporation. So for temporary cases, there's this chamber here, and it's called a nocturnal moisture chamber, and I have one here. It's like a pirate patch. It has foam backing, and it's clear. And after you put your eye ointment in at night, and if you put this on, even if your eye doesn't close, it acts like a greenhouse, so there's less evaporation of the tears and the ointment that you put in there. People can tape the eyelid closed or wear a sleep mask, and that works for many people, but sometimes that's not enough, or the tape irritates the skin because they have sensitive skin, or they're doing it for so long it's too irritating. This tends to work. Again, this is a temporary one. They're not that expensive, but you can't get them over the counter. We have to we get them from a medical supply store. So and they don't last too long because the foam breaks down. Now, having said that, there are other things that work well. This is called Tranquil Eyes. I'll show you I think I have it here. Let me go to the next one. So the website is called Eye Eco, and they have different products. This one is called Tranquil Eyes. It's a luxury eyewear. It's kind of a softer rubber here, and the back has memory foam, which is washable. It has inserts so that if you like something that is holding the eyelid closed, okay, if you have deeper or flatter eyes like myself, that works well. But the foam can also come out, and if the foam comes out, it's kind of hollow and can still act like the greenhouse effect moisture chamber, so it fits right there, and this can be washed. Other things that come with this are cool pads. So if your eye gets irritated, you can put these cool pads. These are like what you put in the refrigerator or freezer, and that you take out the insert and put that in there. That's pretty comfortable. People who have dry eyes often have what we call ocular rosacea, and so there's also heat pads that you can put in there. But really, for facial palsy and dryness, it's really the decreasing the evaporation. So if you put that on at night, that's helpful. And you can get, these are online, and there's different sizes that you can use. The other thing that can be used is this here. This is called the moisture release eyewear. So on the back is there's different types, but this is kind of a soft rubber, and when you wear it, it fits closer against your eye. So again, it acts like a greenhouse, and it prevents the evaporation. And it comes in different frame colors, and you can get clear or different types of tint. The nice thing about this is, I'm not going to take it out of the package because this is a loaner, but it has these little chambers here, okay, little chambers that you fill with fluid. And those chambers pop in on the side here, okay, right here where my finger is, and you fill that with fluid and you put that in there. So not only does it prevent the evaporation of your own tears and whatever drops you put in, but it also releases fluid into the area behind the lens, so it acts like a humidifier, and that's pretty helpful for patients. Now that particular type of eyewear does not have prescription, so it's not great for people with prescription. But people who do wear prescriptions, there's this set of glasses, and they come in different colors and styles, and it's called 7-Eye by Panoptx. So you can get a prescription, you can get it tinted almost like any other glasses. You can get transition lenses, you can get bifocals. That all works in there. The only drawback is if you're very nearsighted, like if you are more nearsighted than a -6, they can't fit the lens in there. This here on the lower right, that's actually the rubber insert that sticks in behind the glasses, and that can be removed, replaced, or washed. So that works pretty well. So there's another question.
Yes, Dr. Ng?
Yes?
I have someone that has a question about covering her eye. Should you cover your eye day and night, or just at night if she's having dryness and other issues?
So I almost universally will say cover your eye at night, because during the day, even if you're doing real well with artificial tears and eye protection, you probably have some amount of dryness and some amount of roughness on the surface of the eye. And so at night, if you get the ointment in there and have it closed, whether it's with tape, the sleep mask, or any of these moisture chambers, it will give your eye time to recover. Your cornea can only take so much of a beating, and once at night, if it can recover, then you'll be able to do better the next day. As far as during the day, that's very individual. Many patients do fine just with lubrication and don't have any problems at all. Others, even with using drops 10, 20 times a day, still can't keep up. So in that case, I do recommend one of these things that I just talked about, because you can still use the eye and keep it moisturized and protected. In very severe cases, sometimes we just, if the patient's eye is really dry, they have to take breaks during the day and put ointment in and just patch it closed. Now, having said that, this temporary one, if you can't afford the others or you're too nearsighted, this one I've had some patients modify it. They can actually cut a little notch on it for the headpiece or the temple piece of the glasses, and then they put it behind their own spectacles, so that they already have, and then when they put on their glasses, this is behind it, and they can still see through it, and that's very helpful. Is another question, Barbara?
Yes, this one relates to that ointment at night. Jennifer asked, I use ointment at night. How do I rinse it out of my eye in the morning so I can read? Since I don't make tears or blink, it's like Vaseline in her eye.
Right. So if you use less ointment and have an occlusion, then it'll be a little easier to rinse out. But usually what I tell patients is in the morning, wash your face so you get the stuff off the eyelids, and then use artificial tears to rinse out. If it turns out that your eye doesn't get too dry and it's too hard to get the ointment out in the morning, even with artificial tears, you might want to try some gels, which aren't as thick as the ointment. And if that's enough to get you through the night without feeling dry in the morning, that might be a little easier to rinse out in the morning. So I would try the gels. Another thing that can be done to help with the dry eye is, say you've done all these other things, you can close the opening of the eyelid tear drainage system to keep whatever tears you make and whatever tears you put in your eyes from draining away. So tears leave our eyes by evaporation, and then they go through the tear drainage system down into our nose, which is why we get the sniffles when we cry. So as far as punctal occlusion, the punctum is the very opening of the tear duct right in the eyelid. So if you were to pull your eyelid down and you see this little bump there with a little hole, that's the punctum. And there's little plugs that you can put in there, like little corks. And what that does is it blocks off the drainage, and you have one in the lower and one in the upper. You can do one or both. And if you do that, whatever tears you make and whatever tears you put on your eye will stay on longer and not drain down into your nose. The only way it goes out is by evaporation. So we tend to do plugs, especially if it's temporary. If we know it's going to be permanent, say their facial nerve damaged their tear gland, and they can't make any tears at all, we'll actually either cauterize it, so we'll burn it closed so it scars closed, or surgically close it so it's permanent, because we know we won't have to deal with the plug falling out or having to be replaced. So here's a diagram of your tear drainage system. So here's the eye, here's the tear gland. If you don't make enough tears, then whatever you put in can just end up going down into the nose. So if we plug this opening right here, then the tears you put on will stay on the surface of the eye longer before it evaporates. So that's most of the medical issues. Now, once you've maximized the medical issues, or if you know there's a permanent issue, then there are things that can be done to help the upper eyelid close. And this, although the eyelid does move, it's called a static procedure because it's a passive closure. So you may have heard of gold weights or platinum weights. These are weights that you put in the eyelid so that it closes better. And the way it works is, remember we mentioned that the facial nerve is the muscle that closes the eye, and then the levator muscle is the one that actually opens the eyelid. So when an eyelid closes, two things happen normally. One is the muscle that closes the eye, which in paralysis patients doesn't work as well, is the closure of that muscle. The other is the relaxation of the opening muscle. So when you close your eye and the muscle relaxes, if you have heavy skin or your brows drooping, the weight might allow the upper eyelid to close. However, if you're paralyzed and that muscle can't close, then adding weight to the eyelid, whether externally, so on the right side here of the screen, there are these external ones that you can tape on to the outside of your eyelid, and especially for temporary patients or someone who doesn't want to have surgery, that extra weight can help the eyelid close because the gravity is adding to the closure of the lid. So although it'll close better, it won't be as fast. So if this eye on my left side, what you're seeing on your right maybe, is not paralyzed and this one is, if I'm blinking, this one will close like this and this one will kind of just do that. If you put in a weight on this side, if you close it, it might close a little better, but it doesn't have the quick closure of a muscle. So what has to be done even with the weight is when you get in the habit of closing your eye and counting for a few seconds, and that gives the extra weight time to get the eyelid to close. Another maneuver that can be done is if I look down, you see my eyelid tracks down with my eyelid. If you look down and then close your eyes, that's another maneuver that helps you blink better, even with paralysis, because if you look down and the eyelid is mostly closed already down here, and then you squeeze your eye, it helps it close a little bit better. So these weights come in different sizes, and we have a sizer, at least in my clinic, and most people who do this a lot have sizers, and you can tape it on the lid and ask the patient, okay, how does this feel? Is it too heavy? And so what you want to balance is heavy enough so that it's comfortable and closes the eye and it feels a lot better closing, versus too heavy where it's just a strain to keep the eye open. So there's a balance, so trial and error is good. So if someone's not quite sure, it might be helpful to try this external eyelid weight first. And if you get used to that and say, well, this really works great, or no, I need a different size, and you get used to it, then you can decide to have one surgically put in. And that is a relatively straightforward procedure. It could even be done under a straight local anesthesia in a procedure room in the office. It doesn't require you to be sedated or anything like that, and it takes maybe about 15-20 minutes to put in. And it is reversible. So if you don't like the lid height, or if you need a different weight, or if you recovered after a while. I've had a patient who had it in for close to 2 years, and miraculously, even after 2 years, had some more recovery, and we ended up removing the weight, and that's not difficult to do. So here's a diagram of where to put the gold weight in. There's two places typically where you can put it in. One is down here, right above where the lashes sit. So you make an incision where the eyelid crease is, and the weight sits above the lashes. The benefit of that is the vertical, it's almost vertically oriented so that when you close your eye, the weight comes straight down and it closes better. The downside is you can see the contour of it through the lid. The other place to put it is higher up in this area here, okay? And the advantage of that is you don't see it, but it requires a heavier weight because it takes a while for it to come across the front of the eye and then drop down. And also if you sleep on your back, since it's on the downslope of the eyeball, it may pull the lid open a little more. So that's the gold weight passive closure. Now on this side, and this is not commonly done for several reasons, there are other methods to get the eyelid to snap close quicker. One is to use a silicone, it's like a rubber band, and you put it across the eyelid. So it's sort of like taking a rubber band and pulling it tight, and you can pull it up and down and let it go and it snaps closed. The other is what you see pictured here on the right side of the screen, and that is a what we call it is a palpebral or eyelid spring. It's made out of the same wire that they used to use for braces, and you have to physically bend it and suture it to the bone and to the eyelid, and so it has memory, so it keeps the eyelid closed. Both the silicone cerclage and this palpebral spring keep the lid closed, and what you do is you fight against it to open, but then as soon as you relax, it snaps closed. So the advantage is it blinks better like a normal lid, but the disadvantage is it takes a lot of effort to try and keep it open, so that can be fatiguing. And the other is, at least for the spring, you can't get an MRI scan. So many patients who have had tumors resected because of the, and that caused the facial nerve palsy, they need repeated MRI scans, so they can't get this done. Also, the metal fatigues and oftentimes needs to be replaced, and since it's under tension, sometimes it can erode through the skin. So most of the time that's not done, but that's a question that does come up. So we have another question.
Yes, Dr. Ng. I have someone that currently has a gold weight. What is the long-term viability of this? Like, how many years do they generally last? And long-term, does it cause like drooping of the eyelid eventually, or what other issues do you see with long-term?
Okay, so the gold weight can last a lifetime. They work great unless you have a gold allergy, which is why they make platinum weights. That doesn't cause a problem. Now, it is a foreign body, so if you were to get an infection or a cut there, or just like people with heart valves or knee replacements or shoulder replacements, if they have bacteria that kind of got spread through their bloodstream, a foreign body is a place where that can lodge, and if that happens and it gets infected, then you have to remove it, let it heal up, and put it back. But those can stay in forever. Sometimes those weights can migrate, especially if you have very thin skin. And if that happens, it looks like, oh, it looks like it's coming out, or it's moving, or it's pushing down on my lashes, then you have to reposition those. And if that seems to be the case, or someone's gotten older and they've had it for years and their skin is getting thin, then I would probably switch it to a higher position like I showed you in the other diagram, but put a little slightly heavier weight in there. And then since it's deeper and there's more tissue there, it's less likely to migrate out. But those gold weights can last for a very long time. Was there a second part of that question that I didn't answer? I forgot.
No, that's fine. No, I think that's it on that question.
So here is a small weight, okay. This patient had partial recovery, but just, wanted to put less tears in because the person was very active. So we put a really tiny gold weight in there, and that was enough to have the eyelid close, and it was so small it wasn't even noticeable. But again, here it shows you where you can put it. This one works a little better, lighter weight, but it'll pull the lid straight down. This one's a little higher up, hidden, but it takes a while to get across the downslope before it comes down. A new thing that's come out is this chain weight, and people ask me about that. I don't put that in very often. The main reason for putting in a chain weight is if you need a heavy weight and it's a single piece, the curvature doesn't always match the curvature of an individual's eyeball, and they might feel it, or they might say, well, it kind of feels a little bit more like pressure on my eye. Then you can do this kind of chain, and what that does is it is a weight, and it's got these joints in it, these hinges, and so it contours a little bit better. The downside is it's a little more expensive, and two, you see there's 2, 4, 6, 8, there's 8 little suture holes, so you have to put more sutures in to keep the movable pieces in place, and it takes a little longer to put in. But also, if you have to remove it, there's more scar tissue around those suture holes and through the joints, so you have to do more dissection to remove it. So usually that's not my first choice, but that is available for patients who need a bigger weight and the weight contour isn't right for them. So that's the eyelid. We talked about other procedures. So if the brow is droopy, and we know this is long term, then you can do something to raise the brow. Now, when you raise the brow, you have to do a procedure above the brow, and if you do that, that gets the brow in a more symmetric position, but it won't increase the movement. So different places to put incisions could be at the brow line, or if someone has deep furrows, you can put it in a furrow. If they have high hairline and they wear bangs, you can make an incision at the hairline, and that's hidden. If it's just in the outer part and the inner part recovered, you can make an incision in the hairline out here or behind the hair here in the temple and raise it up this way. So those are usually covered by most insurance companies as medically necessary. There's another way to raise the brow, and that's by making small incisions behind the hairline and doing a forehead lift. And that works very well, but because it was generated as a cosmetic procedure, even if done for medical reasons, almost all insurance companies won't cover that, but the advantage of that is the scars are hidden. Ectropion is the turning out, or retraction is the pulling down of the lid, usually the lower lid, but also the upper can be retracted. But the lower lid can also be pulled away from the eye. And again, that depends on how much of the face is pulling on the lid. So you can have a weak face because the muscle's paralyzed, but it's not drooping because you have good tissue and not a lot of sagging, and it doesn't pull on the lid. Something like that, we can just make a little incision here and tighten the lid. Again, if it's the cheek pulling down, we can make incisions in the temple and dissect down and do a cheek lift and pull the cheek up, and that gets rid of the flattened nasal fold here, the drooping. It also helps with, some people will have difficulty breathing because the droopy cheek has collapsed the nose, and if you pull that up back where it belongs, it gets the weight off the side of the nose and you can actually breathe better. That does not do anything with the corner of the mouth. If you want to raise the corner of the mouth, you actually have to do a sling procedure where you make an incision in the temple, and we use different materials. There's Gore-Tex, which was used for, before raincoats, it was a substitute blood vessel for blood vessel replacement, so it's biocompatible. And what we do is we sling it down here, we make an incision in the crease where the crease should be, and we pull that up this way, and we pull the corner of the mouth up, and that often helps with drooling or biting the lip. It's not it's a static maneuver, so it'll hold it in position. And so what we try for is, if your face is paralyzed on one side, and this is about here, what we try to do is get it midway so that the difference, whether your face is relaxed or whether you're smiling, is the least different. So in other words, when your normal side of your face is relaxed, the side with the sling may be higher. But when you smile a lot on the normal side, it may be a little lower, but the overall difference at any point in time will be minimized compared to just having one side droop all the time. If the not only if the mid-face is, so the mid-face is droopy here, but if there's a lot of sagging here, then you can have the same procedure of what people have as a facelift, but done for medical reasons, paralytic face, to get rid of this hanging down here and the biting of the cheek, and that combined with the mid-facelift helps quite a bit. So again, that's a static procedure, taking static changes, repositioning it into a higher position so the effects of gravity are not taking effect or not pulling as much, and that helps protect the eye as well. And then for movement type of surgery, muscle transposition, so taking this muscle, so if you clench your jaw, like if you're angry, you get a headache here, this muscle here, if you clench your jaw, that lower end can actually be attached to the lower part of the face and the corner of the mouth. And what you have to retrain your brain to do is instead of trying to smile, you clench your jaw a little bit on that side when you smile, and that'll help contract it. So that requires retraining of your brain to use a different nerve to move your face, but not too difficult to do. More complex procedures require transferring muscles and nerves and grafting, but that takes a long time, and the nerve doesn't always recover. And only very few special centers do that well. And there's one in Southern California, and then the other one that probably has the biggest track record is in Boston at Massachusetts Eye and Ear. So that's the paralysis, and now we're going to shift into unwanted movements, synkinesis. So remember we said that if the nerve regrows back, it can grow back the wrong way. So a lot of it is just realizing, oh yes, when I do this, my eye does this. So there was one example where a patient really loved to read, and the lid closing made it impossible to read. But the synkinetic movement was when she raised her eyebrow, the eyelid closed more. So unconsciously, unless you knew that, you know, the normal reflex, if you want to see more, is to raise your brow. But that normal reflex, every time she raised the brow, the eyelid closed more. So one was just saying, that's what happens, don't raise your brow. That helped a lot. And then also you can give Botox to weaken that a little. So with the unwanted movement, there's different physical therapists that I've worked with. Wanda Crook, she works with Block and Ideal, I think, in Wisconsin. In Portland, there's someone, Wanda used to come up here quarterly, but not so frequently anymore. So I work with her. She's down in San Diego. And then I also work with someone at OHSU who's started doing this as well. And so what they do is they evaluate what the synkinetic movement is. Oftentimes there's a lot of contracture and tightness. So learning the anatomy, where the muscles contract, so you have an understanding of what is happening to your face when you're doing certain movements. Then there's kind of stretching the tight muscles that have occurred. And then there's also your own stretching to get rid of that tightness, so you're not, you know, biting on the bunched up lip. Massaging, heat is often helpful. Being aware of the different synkinetic movements. Looking at where you want your face to be and trying to train yourself to train your brain to make certain gestures to try to compensate for the miswiring. Sometimes biofeedback can help. So if you see, okay, I need to make this go up, and I do that, and yes, my face moves with that, that's very helpful. And then once all this is done, if there is significant contracture that can't be addressed with stretching and exercises, that's where we get into the Botox. So oftentimes the patient will see Wanda or Margaret, and there'll be a certain amount of tightness that they've worked on, and they'll say, okay, we need Botox here, and we do that, and we work back and forth and try to coordinate those things. So you know, the main things are to try and prevent complications, figure out if you do have synkinesis, retrain, and then the selective Botox. And then the tearing I mentioned was the selective or the artificial tear duct for crocodile tearing. So Botox is not just for crow's feet. We have another question?
Yes, you may have answered this. He wrote, "Hi, this is Brian from Milwaukee. Thanks for doing this webinar. Most of my movement has returned after Bell's palsy, but I have a pretty constant blepharospasm." Did I pronounce that correctly?
Yes.
"In the muscle under my eye now. I know the Botox is an option to help this, but I'm hesitant to go this route because I have had so many problems with incomplete closure and dry eye. Are there other options available that you haven't touched on?"
As far as the synkinetic movement, unfortunately, there are not great options for that. Now, having said that, if you've looked online about using Botox, the most common reason for Botox is benign essential blepharospasm. So that's kind of like a Parkinson type of maneuver where there's very forceful contracture, which you can't open your eyes at all. Those patients tend to need Botox in much higher doses, so anywhere from like 30 to 100 units. For patients with synkinesis, we're talking very small amounts. So usually if someone is just going to start out and try to consider Botox, who's had facial nerve palsy and synkinesis, we start with really low doses, like maybe 2 units in the area, and just say, okay, how does this work? And so it's better to, in facial nerve palsy patients, to start at very low doses and work your way up, okay? And sometimes the initial dose, or once you get the muscle relaxed, sometimes doing that and then stretching will make it so that you don't need Botox as frequently as someone with blepharospasm, which is like every 3 months. I've had patients who come in anywhere from 3 months to once a year, or even 18 months, and it lasts a long time. So unfortunately, there's not an alternative to that, because others require weakening the eyelid, and that'll leave you in the same position. At least Botox is reversible. You can try it at a low dose, and if it helps, that's great. And if it doesn't, you got to deal with the dry eye and let it wear off. We have another question?
Yes, Dr. Ng. I have someone that's asking, before they do consult a specialist, what would be some tests or diagnostics that you would suggest for their local ophthalmologist or neurologist to perform?
So one, from the ophthalmologist standpoint, the main thing is going to be what the health of the cornea is and how much protection your eye has. And you can, again, start with measuring the tear production, because there's little strips that you can do to measure the tear production. If you have decreased tear production, then you have to be more aggressive at using tears and protecting the eye and having a shorter or a lower threshold before considering surgery. Now, having said that, unfortunately, even within the ophthalmic community, there's not enough education. There are many patients that I've had that have gone around for years with, their eye in bad position, or they're told, well, the only thing we can do is kind of sew your eye closed to protect it. And that used to be the case many years ago, but there's a lot that can be done, as we mentioned, and not everyone knows that. So I've had patients, like I said, who've walked around for years with lots of problems, and they said they were told there's nothing can be done. So if they say there's nothing can be done, that could be the case, but I would probably get a second opinion in someone who has a lot more experience in facial palsy. And you can always contact me, and if there's a particular question, I can say, well, this is something that's available. You can seek someone in our subspecialty to do that. And the people who do oculoplastics, there's an organization called the American Society of Ophthalmic Plastic and Reconstructive Surgery, ASOPRS. And there's a website, and you can go on that and find a local oculofacial plastic surgeon in your area who would probably have more knowledge than an ophthalmologist who doesn't have that subspecialty. More questions?
Yes, thank you, Dr. Ng. This will be our last question for today. I just have someone that's asking if they can get a list of all the products that you have suggested today, like the specific products.
How about I send that to you, and then maybe you can put something out on your website?
On the website, yes, that would be great. Yes, we can do that after, within a few days. When we put your presentation on the website, then we can also.
Right, actually, all that stuff's on. I think I took pictures with the names of those things, but I can list it as well.
Yes, yes. Okay, this will conclude our presentation for today, and thank you so much, Dr. Ng, for this informative
Thank you for attending. Look forward to doing it again.
Wonderful. And thank you to everyone who's attended online today. And we will have this recording available on our website probably within a week or so. And we'll also put the list of products suggested there too. And again, thank you to everyone for attending.